Alrighty, hi everyone. We're gonna get started in just a minute. For those of you joining us, welcome to our Instagram Live. We are just waiting on, Dr. Sachs, you're with us.
Hello, Holly. Good to see
Good to see
you.
you as well. I was just saying, we're doing this Instagram Live in honor of National Infertility Awareness Week. Thank you, Dr. Sachs, for joining us. She is one of our amazing reproductive endocrinologists. And during this session, we're going to answer questions you have about fertility, fertility treatments, hormones, everything in between, and answering as many questions as we can during this session. So feel free to drop your questions in the chat and ask away. So we've already had a few questions come in. So Dr. Sachs, just to get started, can we talk about supplements and if there are any supplements or vitamins that a person or their partner can take to conceive, to improve their chances of conceiving?
Absolutely. I love this question. And Holly, I'm so excited to be seeing you wearing your orange for National Infertility Awareness Week. I just want to say hi to everyone out there, my fertility warriors, my advocates, my friends. Thanks for tuning in. Let's dive into some questions. So supplements, that is such a hot topic. We see all these influencers online, lots of targeted ads. You need this, you need that. Honestly, the best evidence is going to be for my women out there taking a prenatal vitamin, even months ahead of when you're planning to get pregnant. We really want that folic acid, those stores, to be up in your body before conceiving. So at least 400 to 800 micrograms a day. And then some of the supplements that are a little more well-researched are going to be in the antioxidant categories. And for both men and women, I recommend coenzyme Q10, also known as CoQ10. Vitamin C and vitamin E have also been beneficial. And then there's some other nutrients specifically to males like L-carnitine or zinc that have also been helpful. And on the female side, myo-inositol and even melatonin, which can help with sleep at night. Now, I do want to be very clear that for women taking any of these supplements, I certainly recommend that with a positive pregnancy test or an embryo transfer, I would want you to stop all of those supplements except the prenatal vitamin. And I also do want to mention a prenatal vitamin with DHA. It would be recommended. But fortunately, FCI actually does have a partnership with Luminary Vitamins, and there's a whole subcategory of what we call the Create vitamins that have been very beneficial. So great option for our FCI patients, and there's even a discount available.
Okay. Thank you. I saw a question in here about low sperm count. If you have really low sperm count, what should you do next?
That's a great question. So we certainly want to see certain targets on our semen analysis parameters. The most important categories are going to be, first of all, the concentration. So how much sperm are we looking at under the microscope? Usually we want this to be at least 15 million per milliliter. And then additionally, the motility, or in other words, what percent of the sperm that we see are moving around. We want that to be at least about 40%. The last important parameter, I would say one of the most important, is morphology. How do the sperm look? Do they have normal heads? Do they have normal tails? And we report that in percent of normal morphology. We want that to be about 4. Now, we have different stratifications on the severity of any abnormalities that we see on semen analysis. If I see a patient with no sperm, I want to refer them directly to a reproductive urologist. This is a specialist who focuses on the male side of things, and they'll be able to do a comprehensive workup, make sure the hormones are checked in other relevant metabolic labs, and then additionally may even prescribe some medications or surgery to obtain sperm. So it really depends on the severity, but there are so many options out there. So if you have been diagnosed with a severe abnormality or really any abnormality, it's time to start seeing a specialist, and we have that particular specialist available in our office. He's fantastic.
Yeah, so reproductive urologist, different than your typical urologist, right?
Exactly. We would not want to give them a speculum, in other words.
Can the shape or tilt of a uterus or cervix affect the ability to conceive naturally is another question that we have.
A great question. I have so many women come to see me in the office and go, just so you know, it's hard to find my cervix. I've been told I have a tilted uterus. I will tell you, it is so common. I like to think of the uterus almost like a deflated balloon, but it's a balloon with a very amazing potential and super muscular walls. So really that deflated balloon can kind of tilt any which way in the pelvis. It can change even with things like having a more full bladder, a less full bladder, because the bladder actually sits right in front of the uterus in the pelvis. In that regard, it can tilt every which way, but most women are going to tilt forward. When the uterus is tilted backwards, it doesn't limit fertility whatsoever. It doesn't cause pregnancy complications. And for a seasoned gynecologist, it shouldn't cause too many issues with finding your cervix. So nothing to be worried about if you've been told you have a tilted uterus. It's very normal finding.
Someone in our chat is asking, is there stem cell therapy and can it play a role in sperm production?
That is a great question. So there's been no substantiated evidence that really determines whether stem cells play a role in kind of commercially available options for fertility treatment at this time. It's challenging because we know that sperm and eggs come from certain cells that potentially could be influenced by stem cells. So I'm curious to see what future research shows, but right now it's not a treatment option that I would say is available to our patients or one that we would recommend.
And to anyone who's joining us, if you have any questions about fertility or anything in between related to the field of fertility, please feel free to ask Dr. Sachs. We are answering all of your questions today. Another question that we had, if you're on birth control for a really long time, can it cause fertility issues later?
Excellent question. So this is something that I hear time and again, patients saying, I was on birth control for 10 years, 15 years. Is that why I'm having difficulty conceiving? And the answer is likely no. We have great evidence on multiple hormonal contraceptive options over time, and they really should not reduce your fertility whatsoever. Now, that being said, it can take a couple of months for return of regular menstrual cycles because a menstrual cycle comes after ovulation. Normally with this hormonal methods, we're suppressing ovulation spontaneously, and therefore it takes a little bit of time, usually no more than a couple of months. Now, I do want to mention with the Depo-Provera injection, we have found that it might take a little bit longer, even up to 12 months for return of ovulation and menstrual cycles. But that being said, it should not reduce the fertility whatsoever. And I do want to be clear that there are plenty of patients who may actually better preserve their fertility by taking contraception. But for instance, women with endometriosis, suppressing those hormonal lesions in the pelvis can actually preserve those reproductive organs. So when they're not trying to conceive, it may be beneficial to be on a medication like a birth control pill. Similarly, polycystic ovarian syndrome patients, having regular menstrual cycles while on some form of hormonal contraceptive may be beneficial when they're not trying to conceive. So we are pro birth control.
Yeah. And what's the right amount of time to try to conceive naturally before seeing a specialist?
Great question. So usually in a heterosexual couple with normal menstrual cycles, meaning occurring about every month or so, and no sexual dysfunction in either partner, it's reasonable to try to conceive for up to 12 months in a woman who's under 35 years old or 6 months in a woman who's 35 and older. Any woman who's 40 or older, it's reasonable to seek a subspecialist's assistance as soon as possible.
And speaking of age, one thing we think about with age is menopause. So is that something that IVF or egg freezing can cause if you're using up more of your eggs in a month in a cycle?
I love debunking this rumor. So yes, the answer is it will not at all. IVF and fertility treatments will not facilitate menopause occurring earlier. It certainly is a treatment option where we're trying to get as many eggs as possible, but there's only a finite amount of eggs that we have access to each month. So a woman's brain is actually sending signals down to the ovary to recruit a whole group of eggs. And usually all but about one of those eggs will be lost and never to be used. Now, women are born with all of the eggs they will ever have. So as you can imagine, when we recruit a group each month, we're depleting our overall reserve. But luckily, most women will have enough to get into their 40s, later 40s, up to menopause around age 50. Now, in IVF, we're preventing the loss of those extra eggs from that whole cohort group. So instead, we're trying to rescue eggs rather than losing any potential eggs. Now, we are, again, not taking extra eggs out of the ovaries or depleting those reserves because the rest are almost being held like in a bank vault for the next month. So long story short, IVF fertility treatments should not decrease that onset, age to onset of menopause.
Perfect. Have you seen cases of women over 40 having an IVF cycle converted to IUI because she stopped responding to the meds, but later had a successful IVF cycle?
I would say we have seen just about every scenario you could think of here. So, in terms of converting to an IUI cycle, I know that is always so disappointing for patients when we're hoping to get to an embryo, whether we're planning to test them or have extra embryos to save from that egg retrieval. But I'm sure that there was a great conversation between the patient and the provider before going forward with an IUI. Now, with those IUI cycles, although we see decreased rates of success usually in comparison to IVF, there's still that chance. So I think using that stimulation cycle to proceed with an IUI likely was the best option in that scenario. And have I seen a patient in that particular scenario go on to do more IVF and succeed? Most certainly. I would anticipate that, there's always a possibility of a lower yield of eggs and embryos and a potential for cancellation in a subsequent cycle, but certainly support shared decision making between patients and providers. And if they'd like to try another cycle, I think that would be reasonable. But of course, I'd want to know more details.
Yeah. This one's also a little specific and a little bit above my head, to be honest. About azoospermia after biopsy, and the doc didn't find any sperm. It says a Johnson score of 2.5, but essentially a chromosome microdeletion is found. Are there options? So this is back to the reproductive urology question.
Yes. No, this is when I wish I could phone a friend and call Sam Oleander, our reproductive urologist. I know he'd pick up, he's so reliable, but I can actually see the little font here. So it looks like the type of Y microdeletion was an AZFC. So I would say with my limited reproductive urology knowledge, and again, I would want to make sure it's a very much partnership with Dr. Oleander in our office. But AZFC, hopefully they would be able to find some sperm following a surgical procedure. There's different types of Y microdeletions that AZFC, B, for example, and with C, it is possible, is my understanding. So I would say certainly going forward with a reproductive urologist and starting that consult appointment for IVF, because with this scenario, if sperm is able to be obtained, it's going to be a very limited amount, and it may not fertilize as we would anticipate other sperm that's achieved through ejaculation. So likely IVF is going to be indicated, and specifically potentially further surgical procedures for sperm extraction. So reproductive urologist and then an REI for an IVF consult for sure.
Yeah. And the good news is, there are all these amazing options out there, right? Mm-hmm. There's always hope, right? Exactly. So another question, is there any way to prevent infertility?
Great question. So in terms of preventing infertility, I would say I would swing it more to how can we best preserve our reproductive health, and really having a healthy lifestyle, meaning good diet, very well balanced, good regular exercise habits, and then additionally making sure that we're keeping up with those kind of vitamins that we've talked about a little bit, and monitoring your menstrual cycles. Are they happening every month? Are you having severe pain with them that's keeping you from daily activities? Are you tracking ovulation, and does that seem to be somewhat normal? If there are any concerns, not delaying seeking care from an OBGYN or fertility doctor, because cases like endometriosis, where we typically have very severe pain, can get worse with time. And so really just, I would say, keeping up with good health practices, monitoring the menstrual cycles, and getting help for any kind of sexual dysfunction or otherwise that's concerning.
And related to menstrual cycles, this is a question I see a lot. So if you get your period, does that mean you're ovulating if you have regular menstrual cycles?
Ooh, what a hot question. I love it. So really usually if you're having a cycle every month, I would say that's a good indicator that you're likely ovulating. What happens with ovulation is we release an egg, and then we get progesterone exposure to the uterine lining. And if we don't have a pregnancy, then we usually have a bleed about 10 to 12 days later. Now, if bleeding is very light, if we're having breakthrough bleeding throughout the cycle, if we're having very heavy cycles, I'd say those would be concerning features for potentially not ovulating, but rather having some bleeding from a dysfunctional uterine lining or an unstable uterine lining. So it's certainly good if you have any concerns that you may not be regularly ovulating and have any of these irregularities with your menstrual cycle, to speak with your gynecologist or see a specialist.
Yeah, and how are things like uterine lining, like how do you look at that?
Yeah, great question. So if I had a patient who I did not think was ovulating and was more so having irregular bleeding, I'd recommend doing some labs, checking hormones, tracking her cycles, and doing an ultrasound as well. And that would give us a lot of context information about, is the hormonal ebb and flow normal to what we would anticipate? Is there something else going on that's causing her to not ovulate? Like polycystic ovarian syndrome is going to be one of the most common causes of not ovulating. And that would be kind of my starting workup for a patient like that.
So you mentioned PCOS. What about endometriosis? How do you know if you have it, and how common is it?
Great question. So endometriosis is one of the most common disorders that we see in the infertility world. We say that about 20 to 50% of patients with infertility have endometriosis, but about 30 to 50% of patients with endometriosis will have infertility. So I'm going to take out my little friend for this. This is the little diagram, and I draw lots of pictures in the office, but this is a very tough patient here. She's got a lot of things happening. We have fibroids, we have endometriosis, but you can see these little lesions here occurring throughout, and they pop up, let's see, on her ovaries as well. There it is out here. So basically, the lining of the uterus is called the endometrium. And in endometriosis, glands similar to that lining of the uterus can appear anywhere in the pelvis, abdomen, even in very rare case reports, we've seen it in the nasal passages and the lungs. So endometriosis is still kind of something we're getting to the bottom of, but we've seen it for years and years. So when it occurs outside, it can actually cause scar tissue in these tubes, even blocking the fallopian tubes, so the eggs from the ovary can't get into the uterus or can't meet the sperm in the tube to get into the uterus. So it can cause scarring, adhesions, pain, affect the ovary to reduce the egg reserve, and even affect egg quality. We usually are not recommending surgery just to diagnose endometriosis. And surgery is the gold standard, meaning the number one way that we can definitively say, yes, you have endometriosis. We typically reserve surgery for patients who have had pain that's not responsive to hormones or have had issues with fertility and there's blockage and adhesions. So because of this, we often are more so trialing medications and determining if they respond well, there's a high clinical suspicion for endometriosis. We can also see some lesions on ultrasound in the ovaries, like cyst fluid cysts are fluid-filled sacs, but filled with that endometriosis tissue, which we call endometriomas in the ovaries. So there's a couple different context clues we can use, but overall, the bottom line would be we often are able to proceed with fertility treatments, and that we would not want to delay care because these lesions can be very detrimental to the reproductive organs.
Yeah. So if someone suspects they have endometriosis, they're trying to have a baby, come see you sooner rather than later, right?
Exactly. Come as soon as possible. That's right.
Um, what about drinking with or when you're trying to conceive? So we're coming up in the summer months. It's going to be patio season soon. Do you have to quit drinking if you're trying to conceive?
No.
On both sides, male and female.
Yes, this is tough. I hate being the buzzkill, especially with those, patio season coming up, just like you said. Usually we see that, if there's a woman who's trying to conceive, I would recommend alcohol cessation because you can conceive at any point. We wouldn't want to expose a pregnancy since we know there's no potential safe limit of alcohol exposure to a developing pregnancy. Now, in women who are trying to conceive and preparing for something like fertility treatment coming up, usually under 4 drinks a week is going to be okay. Now, there's a lot of mixed evidence out there. I also like to tell patients, what are you comfortable with? Do you think, having a glass of wine once a week is going to really make you feel guilty? Then don't do it. But if you feel like I want to let loose, I want to have whatever it may be a couple times a week, I'm doing IVF next month. Some research has showed maybe less than 4 weeks a drink. Oh my goodness, 4 drinks a week for women. Now for men, we see a little bit more leeway, potentially up to 7 to 14 drinks a week before we see any kind of detrimental effects on the sperm. However, there has been some really hot research out recently, and this was done in mouse studies, about alcohol exposure even 3 months before trying to conceive, specifically in males. Now, I can totally understand the sperm and the eggs are recruited about 3 months before they're fully mature and have a chance to meet. So in theory, you want to take those 3 months and, even as we mentioned beforehand, being as healthy as you possibly can. But at the same time, I would start limiting alcohol in that regard about 3 months ahead of time or so if you can.
Perfect. I find this question super interesting. I'm getting ads for tracking infertility with expensive products and monitors. How effective are these?
Yes, I get these targeted ads all the time too. I am a huge proponent of women tracking their cycles, tracking ovulation. I think it's helpful to have more information. And I always suggest to patients, if you are trying to conceive and you're doing something like ovulation predictor kits, the best and most important times to have sex are going to be on the day of your surge, which is usually monitoring a hormone called luteinizing hormone, or LH, and the day after. Now, there are so many options available on the market. I personally like the Clear Blue Easy kits. I think, as the name entails, they're a little easier to follow. They're not going to totally break the bank. There are many fertility awareness apps and certain other more involved tracking options where they're looking at different types of hormones. Now, I always think it's fascinating. I love when patients bring me this data, but it's not something that I'm recommending just yet because it doesn't have a lot of evidence behind it. So if you're on the fence right now deciding whether or not you want to go through on something like that, I would say tracking ovulation is usually going to be adequate. And if there's any concerns like early surges, multiple surges per month, chances are those are false positives and you should speak with a doctor sooner rather than later so that we can get to the bottom of that.
Yeah. And you mentioned fertility awareness. And can you talk about, like, what if someone is like thinking about starting to try, or like they're maybe concerned that something's wrong? Is there testing that they can do to or like how do they go about getting testing to see where they're at?
Yeah, great question. So this is another thing that I'll actually get a lot of targeted ads for personally, is those direct to consumer tests that you can do at home. Now, those have not really been validated, and we often are not able to use those in office settings. Recommend repeating. So I would say getting labs and even an ultrasound per the actual medical office would be a great option. At our practice, we do have a fertility awareness program where you can get some labs to determine what your egg reserve numbers are and certain brain hormones to see how is the brain communicating with the ovary. Is it just talking to the ovary, or is it really having to shout? And then additionally, a semen analysis for a partner, because we do see that a third of infertility causes are male in origin. So very important. Those would be great first steps to have. And I would just make sure that you have those completed at a credible medical office so that your providers are able to use those moving forward.
Thank you. And I see a question here about secondary infertility, that someone's hearing a lot about it. We actually just published a patient story with one of our nurses, Caitlin, who dealt with secondary infertility when she was having her second child. And that's on our Instagram page. What are usually the causes of secondary infertility, and is there anything you can screen for?
Absolutely. So secondary infertility, just for anyone listening who's unaware, is usually a couple that has conceived in the past or a patient that's conceived in the past and is now facing infertility and meets that diagnostic criteria. We see that a lot of the causes are pretty similar to primary infertility, or in other words, people who have never conceived, being about a third due to female causes, meaning are they not ovulating? Could it be age-related infertility or decreased reserve? Is there an issue with the fallopian tubes or the uterus? A third being male causes, and then a third being unexplained, which is actually a true diagnosis. The reason that we try to determine what the cause might be isn't so that we can point fingers, but it's so that we can pick the most important and useful treatment options for the patient. So I will say a lot of the time we do have unexplained secondary infertility, and it's just so frustrating, meaning we do the labs for both partners, we do the semen analysis, we do the ultrasound, everything comes back normal, but we see that at a minimum, these couples are probably going to benefit from inseminations rather than timing intercourse on their own. I would say also with secondary infertility, we have metabolic and hormonal changes throughout our lifespan. And as we get older, even if you've had normal periods, you may start to have some skipped menstrual cycles. And you could be diagnosed with something like polycystic ovarian syndrome later in life just because things have changed as you've gotten older. So very low threshold, again, to come speak with us if there's any concerns so that we can get to the bottom of this.
We actually have a question about PCOS. Why is it so hard for people with PCOS to conceive?
That is a great question. So PCOS is one of my absolute favorite things to talk about. So it's such a spectrum disorder, meaning that you basically need to fulfill 2 out of 3 criteria, being irregular menstrual cycles, or cycles occurring less frequently than every 35 days, having polycystic appearing ovaries on ultrasound, meaning multiple eggs, or what we call fluid-filled sacs or cysts, all kind of used interchangeably. And then the third is any clinical or lab testing that shows elevated or is concerning for elevated male hormones, like facial hair growth, especially around the jawline or mustache area, elevated testosterone and other male hormones in the bloodstream, or even like acne. And so again, 2 out of 3, and we can meet the diagnostic criteria. Now, this is important because we find that there's certain treatments that are more effective for polycystic ovarian syndrome. The number one reason that it's harder to conceive is because they're likely not releasing an egg. And we see about 70% of women with PCOS have difficulty conceiving. So first thing we got to do is make sure that we're releasing an egg or ovulating. We can do this with medications by mouth. We can also do this with injectable medications, especially if we're planning to use IVF. And that can often help. Now, egg quality is also a concern with a lot of women with PCOS, and we can't comment on egg quality until we've tried to conceive and we can prove that we're ovulating, or we've tried to make embryos with in vitro fertilization. At that point, there are other options that I also like to try to optimize with my PCOS patients. So I always screen for prediabetes. I always make sure other health labs are up to date, and just determining that is there anything else we can be doing to optimize good health to potentially help with egg quality. But it can be very challenging for PCOS. And I always tell my PCOS patients that Unfortunately, sometimes we don't know until we try, but here's the best protocol I've come up with for you based on your specific lab parameters and your ultrasound, because certainly in PCOS, one size does not fit all.
Are there like certain supplements that are especially good for PCOS, or is it just the same thing? Like take your folic acid, take your DHA.
Great question.
We talked about earlier.
I really love myo-inositol for patients with PCOS. And then if there's an indication for metformin, which is prescription medication, I'll screen for that and usually start patients on metformin if indicated as well.
Great. Well, that is all of the questions that I'm seeing here, Dr. Sachs. Thank you so much for your time.
Of
This was
course.
really, really informative. I know I learned something. I always do.
Good. I'm so glad to be a part of this today. I hope
Yes.
everyone was able to take away a little knowledge and feel empowered during this National Infertility Awareness Week.
Yes, exactly. So thank you so much. And if you have more questions or you think of anything, we encourage you to schedule a consult or reach out to your physician or clinical team so that we can talk more. All right. Thank you, Dr. Sachs. Have
You
a good
got it.
rest of your
Take
day.
care, guys.